Welcome to the show, everybody. I'm Caitlin Hope, here with Professor Heather Murphy. I want to start with a question I get from at least one new grad every single rotation. We'll be standing outside a patient's room, looking at the chart, and they'll whisper, "Wait, is this the one where we dangle the legs, or the one where we elevate?"
Dangle or elevate? That is the classic nursing school hurdle. Because PAD and PVD look like a bowl of alphabet soup until you break down the actual plumbing.
Right. Peripheral artery disease versus peripheral venous disease. It sounds so similar, but the plumbing problem is entirely reversed.
Exactly. And here is my first NCLEX tip of the day. Look at the first letter. PAD is arterial. Arteries take blood away from the heart. So in PAD, you have a delivery problem. Plaque builds up, usually from atherosclerosis, and the oxygen rich blood literally cannot get down to the toes.
Cannot get down to the toes. So if oxygen isn't reaching the tissue, you get what we see at the bedside. Legs that are pale, cool to the touch, and, this is the weird one, completely hairless.
Hairless, yes, because hair follicles need oxygen to grow. If there's a chronic blockage, the body just stops growing hair there. You'll also see intermittent claudication, which is that severe cramping pain in the calf muscles when they walk. They are literally starving their leg muscles of oxygen when they exercise.
Okay, so if PAD is blood failing to get away from the heart, PVD, the venous disease, is blood failing to get back up.
You nailed it. Think V for Venus. Think V for vacuum. The veins are supposed to vacuum that deoxygenated blood back up to the heart. But in PVD, the valves become incompetent. They fail. So the blood just pools in the lower extremities.
It just pools. Which explains why these patients look so completely, entirely different. Instead of pale and cool, PVD legs are swollen. They have that heavy edema, and the skin gets this dark, brown, leathery pigmentation around the ankles.
That brown pigmentation is actually from red blood cells leaking out of the vessels and breaking down into the tissue over time. So, back to your student's question, dangle or elevate? If it's PAD and the blood can't get down, you dangle the legs. Let gravity help pull the blood to the toes. If it's PVD and the blood is pooling, you elevate the legs to help it drain back to the heart.
Let gravity do the work. I love that. But let's shift gears from chronic pooling to sudden emergencies. Because on the burn trauma floor, we get the patients where that arterial flow doesn't just slow down, it stops entirely. Acute arterial ischemia.
And that is a drop everything emergency. You have a sudden local thrombosis or an embolus that just completely blocks the artery. If you don't restore blood flow, necrosis and gangrene can happen within hours. Which is why every nursing student must memorize the 6 Ps.
The 6 Ps. Okay, I'll run through them. Pain, pallor, paresthesia, paralysis, pulselessness, and poikilothermia, which is a $10 word for a very scary symptom.
Poikilothermia. It means the limb takes on the ambient temperature of the room. It feels perishingly cold. If you touch a patient's leg and it is completely cold, pale, and you cannot find a pulse with a Doppler, you don't wait. You are calling the provider immediately for surgical intervention like a thrombectomy or IV heparin.
Within hours, like you said, time is tissue. But speaking of vascular emergencies, we have to talk about the big one, aortic aneurysms and dissections.
Absolutely. The aorta is the largest artery in the body. An aneurysm is a permanent, localized dilation of the aortic wall. It's like a balloon stretched too thin. Most of them are asymptomatic if they are in the abdominal aorta, but a dissection, that's a tear in the inner layer of the wall.
A tear in the inner layer. Ugh. And patients describe that pain in a very specific way, don't they?
They do. If you have a question on the NCLEX or a patient in front of you describing sudden, severe pain that feels tearing, ripping, or like the worst pain ever radiating to their back or flank, you suspect an aortic dissection, especially if they have a history of untreated hypertension.
And the scariest complication there is cardiac tamponade, right? Where the blood escapes from the dissection into the pericardial sac around the heart. The heart gets squeezed so tight it literally cannot beat. You'll see hypotension, distended neck veins, and muffled heart sounds. Remember that from the last podcast?
Muffled heart sounds. That's exactly the hallmark of tamponade. Now let's bring it back to the venous side because we can't talk about vascular without talking about clots, specifically deep vein thrombosis, or DVT, which falls under the umbrella of VTE, venous thromboembolism.
And VTEs are the bane of every postoperative unit. You've got Virchow's triad happening: venous stasis from immobility, damage to the vein wall from surgery, and hypercoagulability.
Virchow's triad! Yes! And the nightmare scenario is that a piece of that DVT breaks off, travels through the venous system to the right side of the heart, and gets lodged in the pulmonary circulation, a pulmonary embolism. This is why VTE prophylaxis is non negotiable.
Non negotiable. So we're talking graduated compression stockings, TED hose, and intermittent pneumatic compression devices, SCDs. But Heather, here's a huge clinical safety point. You use those to prevent a clot. If the patient already has a known, diagnosed DVT, do you still put the squeeze boots on them?
No, never massage or compress a known clot. You will dislodge it and send it straight to their lungs. That is a massive safety violation on the NCLEX and in real life. If they have a DVT, you elevate the limb, warm compresses, and start anticoagulants like heparin or enoxaparin.
Okay, before we wrap up, there's one more spastic disorder I want to quickly hit because it shows up all the time: Raynaud's phenomenon.
Raynaud's. This is an episodic vasospasm of the small arteries, usually in the fingers and toes. It's classic red, white, and blue. First, the fingers turn white from decreased perfusion, then blue from cyanosis, and finally red as the blood rushes back in.
The red, white, and blue toes. And nursing care for Raynaud's is mostly patient education, right? Avoid extreme cold, stop smoking, manage stress. Honestly, submerging their hands in warm water is one of the best immediate treatments for the vasospasm.
Warm water, exactly. Avoid caffeine. Avoid vasoconstrictors. So, just to summarize for our students taking notes, PAD is arterial, dangle the legs, look for pale, cool, hairless skin. PVD is venous, elevate the legs, look for edema and brown skin. And if a patient says they have a sudden tearing back pain, sound the alarm for an aortic emergency.
Sound the alarm, keep that oxygen flowing, keep that blood returning, and always check those pedal pulses. Thanks for listening, everyone. Good luck on your exams.